Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. I trust you are well wherever you are in this wonderful world. In this upcoming video, Professor Brendan Carvalho from the Stanford School of Medicine in Stanford, United States, will be sharing with us his insights into ultrasound imaging for central neuraxial blocks in the obstetric population. If you like any of our videos, do remember to like and share these videos. If you are new to our channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
It's a great honor. Thanks, Manoj, for the kind introduction. And I'm going to talk to you specifically about neuraxial ultrasound in the obstetric population. Now, this is where I live and work. This is Stanford University. I work as an obstetric anesthesiologist and also a regional anesthesiologist. I've been here for the past 20 years and spend a lot of my life with an ultrasound in my hand. Now, COVID has obviously changed a lot of medical practice and how we conduct our lives. But interestingly, in the obstetric setting, it's business as usual. A lot of things have carried on, not without much change. And that's why this is an important topic to be covered. And I'm glad Manoj included this in the webinar series. Before I begin, just to say I have received honorariums from B. Braun and Ravana. I have some contacts with Accuro device, which I may discuss later or will discuss later, and Flat Medical, a loss resistance syringe device. So as you all know, when we do an epidural or a spinal, it is essentially a blind procedure. We use palpation, but for all intents and purposes, we really don't know what we're going to encounter until we start the procedure. And pre-procedure ultrasound provides invaluable information. We know all of these things that it can bring to us, and including knowing midline, depth, optimal interspace, angles of needle insertion, etc. But does all this information make a difference, and does it make a difference in the obstetric population? So where is the evidence for this? And luckily, there are a number of studies, and the overwhelming number of studies have come from the obstetric setting. So this is a recent, in fact, the most recent meta-analysis. It covered 32 clinical trials, so over 3,400 patients, but 22 of which were in the obstetric setting. So a lot of what we know about how effective neuraxial ultrasound is comes from the obstetric literature. So we know it is extremely useful in estimating depth. And a number of studies show an excellent correlation within a mean difference of 3 millimeters. And as Jamie mentioned, this difference can be increased in obese patients without good technique and without releasing the probe pressure when you actually measure the difference. So the 95% agreement levels can increase by a centimeter. Generally, it's going to underestimate, so there's a safety margin, overestimate, so there's a little bit of a safety margin where you're advancing your TUI needle. So the utility of knowing depth is that you know when you anticipate loss resistance and maybe avoid false loss resistance. It's particularly important, as Jamie has shown, for obese patients and knowing what needle to select before you put your needle in, because generally what we do when we don't get loss resistance is we think it's deeper, but very often it's over to one side. The other reason is we're not very good at estimating which interspace we're going for. And this is not our fault. The landmarks we use, the Tuffier's line, is not very good at predicting it. It's only right about 1/3 of the time. And generally, we're 1 or 2 interspaces higher than we think we are. And this is even more exaggerated in Parturients because of more adipose tissues collected on the ileal crest, and generally leads us to think it's higher than we should be. So ultrasound is very useful in identifying the exact space that we would like to put our needle in. In terms of determining the optimal space, this was actually a very clever study that looked at changes during pregnancy, what happens to the epidural space, and which is the best interspace in terms of ease of insertion based on ultrasound features of longer laminal space, more visible dura, and a more shallow depth. And they noticed that it did change over the trimester, so it gets more difficult the more you progress in pregnancy by virtue of increasing depth specifically. And they found that L23 on average is the best interspace. So if you are trying to find a space that's most likely to get into, it's L23. But this is an image in the bottom left of an MRI study where they were looking at optimal window sizes and the different interspaces. And you can see the lower thoracic and upper lumbar being the largest windows as measured by MRI. So if you were again going to select it, it's that sweet spot of optimal space. But what is critical to appreciate is the scatter plots are all the way up, implying that every patient is different, and the utility of using ultrasound to look at this particular individual patient and which interspace has the biggest acoustic windows is very important. All right, so does it really help you get the epidural then? Well, there is, like I mentioned, a lot of studies, 32 trials, 22 of which are on the obstetric literature. There's actually now 4 meta-analyses that have looked at it. So we have very, very good data on at least insertion. And the technical failure risk, that's not being able to get CSF with a spinal, unable to get loss resistance with an epidural, is halved by using a neuraxial ultrasound compared to palpation. You can decrease your needle punctures by increasing your first pass success, decrease redirects, as well as needle punctures. And by virtue of doing all of this, you can actually save time with the procedure. So while you do use time to scan and see the optimal insertion point, you make that time back with your insertion technique. So optimizing insertion has been very well shown. Numbers needed to treat just in terms of first pass success being estimated to be around 5. But what is less known, and something I want to highlight, is it actually leads to subsequently better labor analgesia. And there's a number of studies showing this. Less likely for blocks to fail, less likely to have to replace your catheter, a decreasing need of supplemental medication for breakthrough pain, and even less pain, not only during labor, but for subsequent intrapartum section. And therefore, it's associated with higher satisfaction. Now, why does this occur? Well, there's a number of proposed mechanisms that we think will mention that you get better accuracy in terms of avoiding loss of resistance if you know what depth you should be encountering loss resistance. And this is particularly helpful in obese parturients that may have false loss resistance before you actually encounter the ligamentum flavum. There is some suggestion you're more likely to be midline, and blocks in the midline should work better because you're getting better spread. We actually did a study to try and prove this. We're unable to show it within our study confines. But probably the most likely explanation is you going into the correct interspace. I mentioned the midline study that we did. So what we actually did in this particular study was after an epidural had functioned and we were going to remove the epidural, we calculated how far the insertion point was from the midline and then try to correlate it with the amount of pain the patient had and how much local anesthetic they could use in labor. What we didn't really account for is the insertion site where the catheter is coming out doesn't necessarily mean that where the two went in. So that may have explained why we didn't find a difference. But in meta-analysis data, they actually don't find differences with symmetry of blocks or adequate dermatomal level using ultrasound compared to palpation. So again, the midline theory is probably valid, but it just hasn't been proven. And the data for optimal insertion probably explains it all. There's a very elegant study where they deliberately put an epidural either in L1-2, so a high placement, or a low placement, L4-5. And what they found is the high placement worked well during first stage labor, But in second stage of labor, it was too high to be effective for the sacral aspect of pain. Because as you know, as the baby descends, pain goes from a contraction pain, which is more visceral. And as the baby descends down to the sacral canal, you get more of a somatic intense pain. And if you're up in L1-2, it's unlikely you're going to cover those dermatomes adequately enough to take away pain. There was another study that looked at it, didn't really find a difference. It was underpowered. They found a 91 versus 81% S2 block after initiation of block when they were using ultrasound compared to a non-ultrasound guided technique. But this is the leading theory why we get better subsequent functioning analgesia. Now, does it improve safety? Well, there's a number of theoretical reasons why it would. You're identifying the correct interspace, you're unlikely to go high. And like I mentioned, if you're at least 1 or 2 interspaces higher than you think you are, and the spinal cord ends at L1-2, and you think you're at L2-3, but you're actually at L1-2 or T12-L1, you can see how the risk, there is a risk of being able to hit the spinal cord. Equally for neurological risk, there's a good association when you look at traumatic placements of having multiple needle passes, and by reducing a number of needle passes, you should if you do enough cases and neurological injuries, reduce that. The problem with the safety is it's always a secondary outcome, and the level of evidence has never really been there. So I'll show you the best evidence we have currently for safety. So this is from a recent meta-analysis from Young and colleagues with 22 obstetric studies. And I've bolded the incidence data that they found difference when you're using ultrasound versus palpation. So they showed decreased bloody taps or vascular cannulation, traumatic placement, no difference in paresthesia or neurological sequelae. I wouldn't expect differences in neurological sequelae with such a small number of patients and how rare this were to occur. Interestingly, they found a difference in postpartum back pain, and this may be due to less insertions with the needle and more like midline placement that is less painful than more lateral placements that go through more muscle mass. They have not found a difference in dural puncture. Again, it's a rare complication. 1%, you would need several tens of thousands to show a difference. But curiously, they found a difference in postpartum headaches. And again, I'm not sure why this effect was shown. Now, a lot of the studies look at patients with normal anatomy, and it's this sort of anatomies and obesity that really we struggle with a lot more. And I know there's going to be a lot of talks on this, so I don't want to go too much in this area, more than to say that about 4%, estimated 4% of neuraxial blocks turn out to be difficult. And with difficulty, you get increased complications, both inadvertent dural puncture. In fact, it's estimated for every 1 centimeter deeper you go, you increase your accidental dural puncture rate by 19%. So difficult placement and more likely to have complications. So this is where neuraxial ultrasound really becomes extremely beneficial. So the labor studies that have looked at obese parturients and the advantage of using neuraxial ultrasound show the following. So in one study a number of years ago by Grau and colleagues found less insertion attempts and fewer catheter advancements, taking all comers, both obesity and then predicted difficult back spine patients. In 2 separate studies looking at purely BMI, one using a cutoff of 35 and one of 40, found again less time, fewer needle passes, and a trend towards a lower failure rate, so 4% versus 9.3%. So again, showing the utility in the obese obstetric population. Some of these studies were covered by Jamie for Cesarean spinal anesthesia with a BMI of 40, again showing the same theme of less punctures, fewer attempts, higher first pass success. You can see the percentages on the graph from the 2 different studies, and shorter spinal time. But what wasn't highlighted, which I think is extremely important, because I lived through the era of using peripheral nerve simulator for regional blocks, which worked great until they didn't work great. And ultrasound has eliminated those difficult cases. And this study showed that for cases that required more than 10 passes, it was 1 versus 17. So you no longer blindly struggle to find a space if you have some help from an ultrasound device. In another interesting study where instead of looking at BMI, and BMI is a global measure of adiposity, and what we care more about is actually distribution. So what they did is they randomized patients based on just poor palpation. So if they couldn't feel good landmarks, they went ahead and got the ultrasound and was randomized to ultrasound or palpation, and they found fewer needle passes with this technique. What is interesting, which highlights the importance of fat distribution, is the BMI in the study was actually similar between both groups. Again, explaining that the BMI is not a very good measure necessarily of difficulty you may encounter with patients. It really depends on where the fat is distributed. When I leave obesity now, I just want to mention 2 things, and Jamie did touch on it. I think it's extremely important when you approach a obese parturient, and we have super obese parturients in the US. With an ultrasound, appreciate that your image quality is not going to be what you normally get in a non-obese parturient. And so set your expectations walking in there. But one thing is for sure, you will always get 2 very, very useful pieces of information. And the first one is you will know where midline is. And you know that because you can look at spinous processes. Spinous processes are going to be relatively close to your probe, so you will see the hypoechoic structure, and that, at least if you measure 2 of them, you have some measure of where the midline is. And then you will get a measure of depth, but you have to be a little clever. The trick I use is I look for transverse processes. They're more likely to be seen in ultrasound, hypoechoic structures, and that generally directs you towards where you would expect the ligamentum flavum to be. And as Jamie showed you nicely, parasagittal view can be very good, and the correlation between parasagittal view and transverse view in terms of depth is very, very close. So you can get a good surrogate for depth and midline, and together with those 2, you can significantly help in this setting. All right, so that's what I think about it. So what do the recommendations show? So the National Institute of Clinical Excellence already in 2018, while they admitted there is limited data, still say it appeared safe and may be helpful in achieving correct placement. So they did give an endorsement already in 2008. Since then, we've had a lot more data. And as Jamie highlighted, there is now a Society of Obstetrical Medicine recommendation showing that they recommend it for both obese and non-obese patients. So you can use this as justification for using neuraxial ultrasound. The SOAP Centers of Excellence, for those of you not aware of it, it's an award that the Society for Obstetric, Anesthesia and Perinatology give to centers around the world. One of the criteria is to have ultrasound available, and specifically highlighted in blue for neuraxial blocks. So it's recognized to be an important skill for an obstetric anesthesiologist. In a recent meta-analysis, which I've already highlighted by Young and colleagues, they went quite far in their statement, and I just want to read it for you. They said the adoption of pre-procedure ultrasound for neuraxial procedures in obstetrics is recommended, and in the view of the authors, should be considered as a standard of care. We can talk a little bit more about this. I don't know if it has reached the level of standard care, but either way, it's something that is slowly tilting towards it. And having lived through the central line placement, where we used to do blind techniques, and the slow changeover to it becoming the standard of care, I think we're following that same path, be it a lot slower. So why is that, and what barriers have held us back on this particular front? So knowledge and expertise are the two aspects. And the good thing to note, and this is a nice study by Grau from a few years ago, is that the learning curve is actually very flat, and it's an extremely easy technique to learn, other than compared to other ultrasound techniques that are taught in POCUS. You can see the solid line. Already after 10, you're at close to 90% efficiency. So it's a very flat learning curve, whereas the traditional palpation has a much longer learning curve of around 50 to 60 before you get to a proficient level. Now, equipment can always hold you back if you don't have equipment, but luckily in obstetrics, we all have our ultrasound available. So using it for the baby, we have the same probe and the same ultrasound. We just can wheel it across and do a quick neuraxial ultrasound when we need it. We use it so frequently, we actually have two separate standalone fancy machines that we can use for our POCUS and a neuraxial ultrasound. That's how frequently it's used in our obstetric setting. And then the expertise, and you obviously have to learn this, but it's not a difficult thing to learn. There's very good reviews, very good videos online to be able to learn it. It's something that I even had a colleague learn at the time where he turned a video on when he was struggling with the block. He didn't have the expertise to do it, and he learnt it and did it in front of a patient. Don't know if I would have been too reassured with my physician learning just before doing my block. There might be help along the way, and I did mention a conflict of interest from an honorarium I've received from the manufacturers of Accuro, but it's a handheld device that has an image overlay. So it takes the expertise aspect out of it. It image overlays so that not only can you see the depth automatically being shown, but it also has a 3D navigator showing you to move left and right. So it's a very clever device. And it also comes with a locator guard, which you can slide off, indents the skin, so you know exactly to go in the middle. So you can see from these images, the image in B being off to the right, it's a blue line, it's saying it's not quite there. And when you slide it to C, it lights up, it shows you right in the middle, and the depth there is 4.4 centimeters. So a quick device and relatively useful device to use. We've shown that it works pretty well. The difference between the device and the TUI depth was 0.6 centimeters. With high first pass success, and accurate along the entire range from 4 to 7 centimeter depth that we were looking at. But this was a non-obese population. It worked as well as a fancier console ultrasound machine, although the console ultrasound was slightly more accurate relative to the TUI, so 0.33 versus 0.61 centimeters. But both equally accurate in determining midline. And this is in laboring patients receiving epidural analgesia. For spinal cesarean, using the same device, they found in the obese population, they were able to, again, same theme, less needle insertions, fewer needle passes, and that difficult spinal, the greater than 10 passes, was significantly reduced. So this is in a BMI of greater than or equal than 30. There were some larger patients. In my opinion, in very large patients, there's nothing better than a high fidelity ultrasound device. You need all the help you can get. So this is probably the mid-range utility. And a last study using the same device for combined spinal epidural in obese patients, again showing the same things that we've seen with normal ultrasound devices, with higher first pass success, less redirects, less needle punctures. I'm not sure why they found a lower incidence of paresthesia, perhaps being more midline, and then pretty close, and accuracy similar to what we found with our study. Image overlay is not unique to Accuro device, and this is out of a Singapore group that used an image overlay from a standard ultrasound device, and I think this will become standard practice for us when we're doing our techniques where we have image overlays to be able to help us, direct us, and improve our interpretation also giving automatic depth measurements, which would be very useful to the clinician. Instead of having to go through the measurement routine, you can automatically see the number. Okay, so with all these advantages I've gone through, why are we still, not using it in every single patient? I think there are some barriers I showed you in obstetrics. I don't think they are insurmountable. We have the devices and it's a relatively easy technique to learn. But I do think we're still deficient in data, and not so much efficacy. It clearly works better to insert, speeds up the time and all the other things that I've shown you. But the thing that will really move the needle is showing if you decrease dural puncture. And I think that's going to take just a lot more cases and clever study designs to show that. The national recommendations are moving in that direction. I don't think they're necessarily strong enough. It's not become a medical legal standard, at least in the US. So there's still a long way to go for this to be a standard technique for all patients. And I do think we need technological improvements to get over the last hump. Now, I'm a big fan of pre-procedure, and all these studies I've been showing you is pre-procedure ultrasound, but what about real-time scanning? And I know Manoj is a fan, and he's super expert at it and described it very early on. A technique that's very useful in the right patients. And this is a study showing in 60 patients versus palpation, a nice paramedian in-plane approach, significantly reducing needle passes, improving initial success and shorter time to placement. So I have no doubt this is a technique that's useful in the right patient with the right anatomy. But in the difficult patients, and we'll probably hear more about this, it doesn't necessarily solve all your problems. And this is just a table I've taken out of one of the studies that looks at it, but you can see the needle insertion time is actually longer in the ultrasound group and the procedural difficulty being higher. So it really depends on your patient and your image quality, how useful real-time scanning is. But perhaps in between one is this from the obstetric population. This is an obese Parturients of greater than 40, and they had had a failed epidural catheter insertion. This is more than 3 attempts by an experienced provider despite pre-procedure ultrasound. So they just had 10 patients as a proof of concept. They took out the ultrasound and did real-time placement and was successful in most patients in 1 to 3 attempts. They were able to see the TUI 6 out of 10 times, which again is a little concerning if you can't really see the TUI needle. It's imperative to be able to see it all the way through, or swapping to a loss resistance technique without visualizing the TUI when you get close to where the target structure that you want to go. Real-time scanning has issues. You can't use gel because of the neurotoxicity concern, and saline just doesn't work as well. You have to be skilled like Manoj. The average provider is just not going to be able to do it. You need a little bit of help either with an automated loss of resistance syringe, or like I mentioned, get into a certain point, see that you're in the midline, you're pretty close to ligaments and flavum, and then just do the loss, but blindly without watching it go through into the loss resistance. I do think it's important to have good needles to improve the echogenicity and visualization. And I think we'll look back when we have better technology, both with 3-4D images and better guidance systems, and think, did we ever really try and do real time, just manually trying to manipulate everything with 2 providers or 3 hands or whatever we were trying to do. So I think it's just a matter of time as technology improves that real-time scanning will become the standard. So what do I think? Well, I'm clearly a fan of neuraxial ultrasound. I hope I've provided at least very good evidence base behind the practice that we can defend. It certainly facilitates insertion. It improves subsequent functioning in the laboring patient and potentially intrapartum section top-ups. And it improves safety, at least in some of the metrics that I've shown you, but not yet in the big ones, the post-dural punctuatic or neurological complications. And that's just more patients needed. It is a very easy technique. I don't think there's many barriers. At this point in time, it's not necessarily something you have to do in all patients, but don't take the probe out only for the very difficult patients. You have to feel like you can actually use it and use it regularly to be able to do the difficult patients, the obese patients, the scoliotics, the patients with previous back surgery or deformities. And one area that might be useful in patients is doing it as part of your initial assessment as a screening tool, or when someone who gives you a history of having a difficult block or who's had a failed epidural that you're going to replace. So I thank you for your time. Sorry, I'm not going to stick around for questions and answers, but you're welcome to email me, send me messages, and I'll try and answer whatever I can. So thank you very much.